Good evening. I'm Alexander Stratigos. I'm a dermatologist based in Athens, Greece, and I'm also the president-elect of the European Academy of Dermatology Venerology. I would like to welcome you to tonight's webinar titled Melanoma and Skin Cancer Management During the COVID-19 Pandemic. This session is a joint event organized by the EADV as part of its COVID-19 and Dermatology webinar series, and by the European Association of Dermato-Oncology, or EADO. Co-chairing this event with me is Professor Klaus Garbe from Germany, who is the president of the EADO. And I would like to invite Klaus to open the session and offer his opening remarks. Klaus?
Klaus needs to unmute.
Klaus, you should unmute yourself. We cannot hear you. You are muted. Yes.
Can you hear me now?
Yes, of course. Please go ahead.
Okay. So my name is Klaus Garbe. I'm professor of dermatology at the University of Tübingen in southern Germany. And it's my pleasure also to welcome you to our COVID-19 webinar. The COVID-19 pandemic has strongly influenced medical practice in European countries. And in this webinar, we will address the challenges of this pandemic for the care of melanoma and skin cancer. Experts from 8 European countries will discuss how patient care has changed from diagnosis to surgical and systemic therapy in different European countries. Please take the chance and learn from the exchange of experiences during this unforeseen pandemic.
Thank you, Klaus. Thank you, Klaus. Joining us at the panel are a number of distinguished experts, each representing a different European country with a different burden of the pandemic, different pressures and strains in the healthcare systems, and obviously different approaches in the management of patients. I would like to welcome the panelists, starting with Veronique Bataille from London, Reinhard Dummer from Zurich, Celeste Lebe from Paris, Veronique de Marmol from Brussels, David Moreno from Seville, Katie Perez from Rome, and Mito Trakatelli from Thessaloniki, Greece. I'd like to share with you a few housekeeping remarks during the session. The audience will remain at a muted mode to minimize any background noise. Also, the cameras will be off. We would like to invite questions from the attendants, and in the lower part of your screen, at the toolbar, there's a Q&A designated button, which you can press and write down your question and submit it to us. And we will try to cover as many questions possible in the interest of time. So please join us with your questions and your comments. So the structure of the webinar is divided into 5 main themes, and I'd like to start with the first theme, and it's my pleasure to invite the first panelist, Professor Katie Perez from Rome. And I would like to pose the question to Katie. How did you approach patients with suspicious skin lesions, or even patients with established skin cancer diagnosis? And the question pertains also to the peak of the epidemic, but also the period after the peak, after the emergent phase of the pandemia. Katie?
Yes, thank you, Alex. Good afternoon, everybody. It's really a pleasure to be with you. The next slide, please. Italy was one of the first European countries to face the COVID pandemic. And during the emergency phase of the pandemic, the management of skin cancer patients raised 2 main issues. One was to prevent a COVID negative patient to be exposed to the viral infection, and on the other hand, to prevent a COVID positive patient to infect healthcare workers and other patients. Therefore, we prioritized the face-to-face interaction of urgent and clear-cut skin cancer diagnosis, whereas we used telemedicine for atypical suspicious lesions. Non-urgent appointments were postponed and skin cancer screening programs were suspended. Next, please. We used a triage color system to better identify the different situations. Red means that the COVID risk might have been higher than the oncological risk, so we postponed the visit or treatment. An example might be a patient, an elderly patient with a poor general health condition. Yellow when the COVID risk might be high for patients and healthcare workers, and in this case, the tumor board would discuss the patient according to the age or comorbidities, and therefore whether to postpone the visit or switch to a different treatment. Green means that the COVID risk is less than the oncological risk. For example, a clear-cut melanoma or a patient under systemic treatment. And finally, white when the infection risk is low, so we delay the treatment or discuss an alternative therapeutic option. The next, please. So if melanoma was diagnosed, surgical excision and sentinel node biopsy, when needed, were performed. Systemic treatment of metastatic melanoma was initiated. Instead, adjuvant treatment in COVID-negative patient was again discussed on a patient-by-patient basis by the tumor board. But we also should consider that during the emergency phase, surgery was performed according to the priority list of operating rooms and the limited availability of anesthesists. The next, please. As far as non-melanoma skin cancer is concerned, advanced BCC were not treated by surgery in most of the cases. Instead, we considered the radiotherapy or HER2 inhibitors. For squamous cell carcinoma, we performed the surgery whenever possible, but we also considered radiotherapy or immunotherapy as first-line treatment. In case of COVID-positive patients, the case itself was discussed again by the multidisciplinary tumor board. We also had dedicated pathways, for example, radiotherapy specific pathway for COVID positive or SARS positive patients, let's say. The next, please. After the 4th of May, in Italy, we entered the so-called phase 2 after the lockdown. It means that friends and family members can meet again. Some commercial activities are reopened, and therefore the worry and the fear now is a possible new peak of the epidemic curve, although it is not expected as high as the first one. Therefore, in this context, education of healthcare workers and patients and the general population is really crucial. Regarding our daily activities, we increased the cooperation with the GPs, and we also rescheduled all visits of our patient with the checkpoint before entering the department and the hospital, with a longer time for visits, just to guarantee sanitization and to avoid gathering. So, so far, we have been asked to follow this schedule and timing until the end of July. So probably something will change again in August and next fall. Thank you.
Thank you, Katie, for your input. I think I'd like to open this now for comments on the same question. I'd like to hear from David Moreno, who's based in Seville, Spain, about his approach to the same question. How did you prioritize patients for surgical management, David?
I'm going to thank you, Alex. Thank you, Katie, for this nice approach. But I will approach this question in the following. So if you want to avoid any repetition, we can go or to skip to the next presentation to my part. Okay.
That's fine. I'd like to ask perhaps Veronique, who comes from London, and obviously she has a lot of experience on this. I'd like to share her experience. Would you like to share your experience with us, Veronique?
Yes, so I think, like all of my colleagues, we were really hit by the lockdown when it finally hit us in England at the end of March. In our trust, just to give a local example, we see around 4,000 suspected skin cancer referral, because the UK has a special 2-week wait referral only dedicated to suspected melanoma and SCC. So these face-to-face 2-week wait appointments stopped abruptly. We then moved to, as quickly as we could, to phone clinics, to some teleconsultation or video consultation, but obviously all of us can appreciate that you didn't have a dermoscopy. However, what was quite surprising was that we were adapting quite quickly, and we were quite good at triaging. We were not as good as precisely giving a diagnosis without dermoscopy, but we were actually quite efficient at triaging patients as urgent and non-urgent, and 80% of the patient could successfully be triaged into needs to be seen face-to-face quickly, and the appointment can be delayed.
Mm-hmm.
Veronica, I have a question for you. Given the fact that the restrictions and the lockdowns, there's probably going to be a long waiting list of patients waiting to be seen. And I'm wondering whether you have a system in place at your clinic or at your institution to manage this increased flow of patients.
So at the moment, we've got probably around 1,000, 1,200 backlog of patients to see quite quickly. Our trust doesn't allow us to see inflammatory dermatosis yet, and we can only see skin cancer and catch up with the patient or waiting. So it would be like maybe well-differentiated SCC, some high-risk BCC, melanoma, of course, have been dealt with quite quickly. And most of the cases so far have to be dealt with a video consultation that allows you to send a link to the patient to send photograph. We are not at the moment allowed to see all skin cancer referral face-to-face yet. They ask us to triage still up until today. But obviously, once we have established that these patients are very urgent, we can see them face-to-face. And we do see and treat on the same day.
Thank you, Veronique. We'll have the opportunity to speak about teledermatology later on. I'd like to switch over to Mito Trakatelli from Thessaloniki, Greece. Greece has been a country where lockdown restrictions were imposed quite early in the course of the epidemic. And Mito, could you please describe to us, how did you triage, how did you manage patients with suspicious lesions?
Hello to all. So Ricardo, I don't know if I have the control of my talk. Okay, thank you. Do you all see my pointer or not, Alex?
Yes, we do see it, yes.
Okay, so as you see in Greece, we have, these are data from this week. We have less than 3,000 confirmed cases and less than 200 deaths. So we are a country that was relatively, if we can use the word safe, from COVID. What happened was we had very early restriction measures. Since March 3, we closed schools and businesses progressively shut down. And then people needed permits to move around. The hospital I work in, Papageorgiou Hospital, closed all ambulatory consultations March 12, including outpatient surgery. And we had restrictions in force until May 4th. So now we are getting back to normal, and since this week we are actually opening more and more our consultations and our outpatient surgery. Next slide, please. Or is it me? Ricardo?
Professor Tracatelli, you can use your mouse, please.
Okay. Mouse. Yeah. Doesn't work, Ricardo. I'm sorry.
It should be working now.
Yep. Okay, thank you. So, and actually it worked too well because it's now moving extremely forward. So what I wanted to say is that during this period, we shared experience with Modena, a hospital that was very hardly hit, and we managed to find a triage, and this is actually the way we did things inspired by the exchange with Modena. The first thing is that for all surgery, we try to be safe, and especially for surgery in the face, we used special protection, and we tested the patients for COVID. So this was very important for us before doing closed surgery on the face. And here you see a scheme for whatever was melanocytic lesions. This is the way we managed it. So there were lesions that had histology, and you see the whole group here before actually the lockdown. So depending on what we had as histology, we decided, and you see the triage was done again, inspired by Katie system. Green is what we went forward and did, and red is what we postponed. So for thick melanoma, we did wide excision and sentinel lymph node according to guidelines. For thin melanoma, wide excision was postponed. For thin melanoma with incisional biopsy, we did perform the wide excision. For in situ melanoma, we postponed the wide excision. And then the lesions that we did not have histology for, if they were strongly suspicious for melanoma, for thick melanoma, or they were palpable, we performed narrow excision or punch biopsy. But for flat, atypical, or dysplastic nevi, we deferred the surgery. Ricardo, can I still move it? Yes, I see my little arrow. So for non-melanoma skin cancer, again, we had the categories of people who had histology before, and according to the diagnosis, if it was infiltrating squamous cell carcinoma of the H area, rapidly growing, ulcerated, or more than 2 centimeters in any location, we did perform wide excision, whereas for in situ squamous cell carcinoma or any BCC, wide excision was postponed. For other diagnoses, it was dealt according to the diagnosis, treated or postponed. For the lesions that we did not have histology, if there were palpable lesions and they were strongly suspicious for infiltrating tumor, we did perform narrow excision if it was possible, or at least incisional biopsy to get the diagnosis, and the flat lesions were postponed. When we did not have an idea of the diagnosis clinically and had no histology, for palpable lesions strongly suspicious for infiltrating tumor, we did perform narrow excision, and for the flat lesions, again, we postponed excision or incisional biopsy. So what I want to be a take-home message from what we did and from our experience is that we need to balance the risk of the tumor and the risk of the COVID, according to the Hippocrates saying, first do no harm. So if it's a low-risk cancer, it's an elderly patient, COVID is more a threat to him than his cancer. So then we can defer the surgery. When it's a life-threatening cancer that needs to be excised, then we treat it according to the guidelines. And when we have to think about skin surgery during this period, and as we're getting slowly back to normal, of course, when we're talking about skin surgery, cancer surgery has to be prioritized compared to other skin surgery. So this is my experience for Greece. Thank you.
Yes, Myrtle, thank you very much. Obviously, we have to balance the need to treat the tumor, to control the tumor, and the risk of each patient for morbidity and mortality by COVID-19. And this is often a case-by-case decision. I think you really covered it very nicely. I'd like to move to the second topic, which is focusing on teledermatology. And this has been a modality that has been extensively used during the pandemic. Teledermatology, telemedicine, teleconsultation, different terms describing the same methodology. And David Moreno, who is again based in Seville, Spain, is very experienced in this field. And I'd like to ask you, David, how did you use this modality for the diagnosis of patients during the COVID-19 outbreak?
Okay, thank you all for inviting. Thank you, Alex, for inviting me to this interesting webinar. First, I would say that the COVID outbreak did got us trained in teledermatology, because over the last 15 years, we have been running a store and forward teledermatology system to make referral decisions in patients with skin cancer and cutaneous lesions suspicious of skin cancer. Next, please, Ricardo. Can I have the next slide? I don't have the control, isn't it? Ricardo, please.
Mouse to take over the control.
Yes, can I have the control? Okay. So next, please. Next slide, please. Okay. So this was our the referral system we have been working with over the last 15 years. Okay. No. Okay. Okay. Right. Okay. Next one, please. Okay, right. Thank you, Ricardo. So this is the referral system, the store and forward teledermatology-based system to make decisions you have been using for the last 15 years to make decisions with the skin cancer patients. In these patients, family physicians take clinical pictures, as we see at the top of the slide. And these pictures, dermoscopic and clinical pictures, are uploaded to a web platform to be assessed by the dermatologists working at the digital area of our dermatology department. If clinical and dermoscopic pictures are consistent with clear-cut benign lesions, the dermatologist delivers a report, a discharge report. Sorry, you can go up, please, Ricardo. Okay, thank you. And then if, as you see here, if the clinical pictures are consistent with clear-cut benign lesions, so the dermatologist delivers a discharge report, and this before 24 hours, and this patient are not referred for in-person visits to our hospital. Otherwise, in any patient with clear-cut primary malignant melanoma suitable for surgery under local anesthesia, these patients are directly referred for surgery with no in-person visits in between. And all those patients below at the bottom of the slide, the right, all those patients with uncertain lesions or large or high-risk tumors suitable for major surgery, most surgery, all these patients obviously are referred for in-person visits at our skin cancer or melanoma clinic. Under these flows, we may reply these reports before 24 hours, as you see there. Patients suitable for surgery, melanoma patients suitable for surgery may be operated on before 72 hours, since we had the teleconsultations. And finally, all these patients who need an in-person visits are attended at our dermatology department before 5 days since we delivered the teleconsultation report. Next, please, Ricardo. See, this was before the COVID pandemic. That's Ricardo, please, the next one. Okay, this is this type of the pictures we usually receive from primary care centers, pictures taken by the family physicians or nurses, staff nurses, pictures that are very high quality, that enables us to make ready decisions with malignant lesions. And even as the lesions you have at the right bottom line, we can also make ready decisions with clear-cut benign lesions on dermoscopy. Next one, please, Ricardo. Okay, this was before, as I mentioned, this was before the COVID outbreak. But Spain has been the next one, please. Spain has been among the leading European countries in the number of confirmed COVID cases, COVID patients, with more than 200,000 cases and roughly 30,000 deaths. And consequently, we have undergone a harsh 2-month confinement period that we're now progressively leaving. Next one, please. And under this confinement, next one, this confinement and with primary care providers struggling to cope with COVID patients, this teledermatology program was stopped. And so we had to launch a user-friendly tool to directly receive pictures taken by the patient themselves, with the pictures taken with their own cell phones. As in-person visits were also not allowed at our department during this confinement period, except for life-threatening conditions. Our only aim with this approach was to identify malignant melanoma patients to be directly referred for surgery. As you see here in terms, next one, please. Okay, we're now, okay, here the pictures we have received from patients, pictures taken by patients themselves using their cell phones. From the quality point of view, nothing to do with pictures taken by a trained, well-trained family physician. However, even with pictures like this taken by the patient, that far from being perfect, we have been able to identify highly suspicious lesions in patients who were immediately and directly referred for surgery and then confirmed as malignant melanoma afterwards. Next, please. Okay, now we are overcoming the hardest past, or the hardest part of the COVID outbreak. And then we are restarting our teledermatology program between primary care providers and our department. But after this experience, favorable experience, we undoubtedly will keep this direct to patient teledermatology flow, the yellow one, the yellow line, just in case further confinement periods have to be faced. So this has been our experience in managing skin cancer patients' access and referrals during the these months of COVID pandemic. Thank you.
Thank you, David. I'd like to open the discussion on the same topic among our panelists. And Katie Paris from Rome, I know you've used teledermatology extensively in your service. What are the advantages and disadvantages of this modality, at least during the outbreak?
Hi, Katie.
Katie?
Yes.
Yeah.
From my experience, I must say that we used extensively teledermatology to assess, for example, the laboratory examination of patients who were chronic, stable somehow. So we could even ask for side effects of treatments. So we really used a lot regarding this type of application, but I have some, I think that there are some bias when the patient select, for example, the images. We didn't have a very good quality of images by patients and GPs. So I think that these are the disadvantages and maybe the field where we should improve.
Great, Katie. Thank you. And Veronique Bataille, again from London, UK. Do you think that teledermatology will become more incorporated into our standard care and standard way of diagnosing or following up patients in the long term?
So I think, I mean, as you're all aware, we have the lowest number of dermatologists in Europe per population. So teledermatology was always ideal for the UK situation, but compared to our Dutch and Spanish colleague, we were really way behind. And I think there was quite a big reluctance from the UK dermatologists to accept the teledermatology system widely. However, prior to COVID, teledermatology had started to infiltrate a lot of departments in the country, but rather slowly, rather reluctantly, but eventually it did. So the trust that already had teledermatology were really major advantages when lockdown occurred. Our trust already had it. And really what happened, a bit like Professor Moreno mentioned, is that we couldn't bring the patient to take a fantastic picture, or the GP couldn't take any a great picture with dermoscopy. And that was obviously the big difference in our practice. But as I mentioned earlier, we were surprisingly quite efficient, and using the system with only the photograph from the patient that was sent with a secure link, up to 35%, depending on the consultant who did the referral, obviously, because not everybody has the same kind of habit of discharging or not discharging. Up to 35% were discharged outright, so no follow-up whatsoever for skin cancer suspicious lesion. 40 to 45% were sent directly to biopsy list, and obviously prioritized depending on the suspected diagnosis, and the rest were delayed for a further face-to-face follow-up when the lockdown was over.
Thank you. I'm receiving several comments by attendants about positive comments on teledermatology, the way they use it in their practices as well. Klaus Garbe from Tübingen, Germany. I know that you've been involved also in the study of teledermatology. Not sure whether that was within the outbreak or outside the context, but could you give us your experience as well?
So we have a special setting. That means general practitioners do the focus and send them to us, and we give back a diagnosis, also a statement whether the patient should come to the dermatology department. And this particular for skin cancer. And our experience is, even with macroscopic pictures, you can make rather accurate diagnosis. And I wonder how long David did train the primary caregivers to get such excellent dermoscopic pictures, because those kind of dermoscopic pictures do we not receive. David, could you tell us about how did you train them and how long did you train them?
Yeah, well, we have been working with this system for 15 years, more than 100,000 pictures taken and submitted. And so our percentage, our proportion, current proportion of low quality pictures is below 3%. So it's a matter of training, it's a matter of experience and nothing. We deliver a very brief training at the beginning of when we launch a center, and when we include a center in the program, it's just a training, a 1 hour, 2 hour workshop with people who is going to take the pictures. But the only secret is hundreds and miles and thousands of pictures taken and submitted. Okay.
Okay, thank you for your comments. We're just gonna make a small break for questions by the attendants. We have a couple of questions here. One question is addressed to David and Myrto about the potential postponement of sentinel lymph node biopsy and wide excision in patients with melanoma. How long can you postpone these procedures, and whether this was a decision that was based on the tumor thickness? Was it done for all types of melanomas, or did you prioritize thicker melanomas compared to thinner melanomas? David, can you please respond?
Yeah. Regarding melanoma patients, melanoma surgery, we have been operating on any patients presenting with a primary malignant melanoma, just for excisional biopsy. What we did change during the COVID outbreak over these months was that with these patients, these melanoma patients at the hospital for surgery, we have been carrying out point of care regional lymph node ultrasound. In case of negative ultrasound, most of the patients, except for just one, and accordingly to international recommendations like the NCCN or ESMO recommendations, we have postponed wide excision and sentinel lymph node biopsy. Actually, we're now planning these weeks, we are planning all these postponed procedures, which will be finally performed with delays shorter than 2 months, these delays in case of wide excision and sentinel lymph node biopsy are not expected to have a negative impact on the patient. In contrast to the NCCN recommendations, we have not deferred lymph node dissection of any patient presenting with lymph node metastasis detected clinically or by ultrasound or any other imaging test. NCCN guidelines propose replacing this surgery by neoadjuvant therapy, but our melanoma board, and considering the situation that we're proud of our hospital, we didn't see any advantage of in this approach in replacing lymph node dissections by neoadjuvant immunotherapy. This was our experience over these 2 months.
Thank you very much. And Myrto, would you like to make a comment on the same question?
As I said, we did not defer for the thick melanoma sentinel lymph node. So actually, we did perform sentinel lymph node, so we did not adhere to the theory that this should be deferred. So for all sentinel lymph nodes that there was an indication to perform, we performed it. So that's my answer.
Good. Thank you. There's a question about testing for COVID-19. One question is about testing medical staff and paramedics. And the other question is testing patients who are planning to undergo surgery or are scheduled to receive immunotherapy. Do we have any experience on that? Maybe I can ask Veronique Bataille, what is your way?
We're probably not the best example because we were in a very difficult situation in the UK for April, where none of the doctors, paramedics could be tested for COVID. We didn't have any availability to be tested as a medical practitioner. And most of our patients were also not tested unless they came with severe symptoms where the clinician had to make decision as whether their symptoms were definitely COVID driven or not. So that was a very difficult situation, and relevant to melanoma, oncologists as well were in a difficult situation where they may have had some side effect of immunotherapy and they didn't know whether this could be driven by COVID. However, by the end of March, the government finally got the testing sorted, and now all medics, paramedics, anybody involved with healthcare, and all patients coming through either surgery, immunotherapy, infusion has access to COVID testing. But that doesn't mean every outpatient who comes for skin cancer surgery, they can't provide that.
Okay, and Klaus, what is your experience from Tübingen on the same question? Do you test patients before surgery?
Yeah.
Or?
So we had not a single patient with symptoms for COVID-19. Among, I think, 200 patients who are under systemic treatment, mainly under immunotherapy. And so now we made up a plan that we will test all our patients who are under systemic treatment in order to find out whether they have asymptomatic causes. Yeah. This is possible. Maybe that even immunotherapy is a good therapy against COVID.
Thank you, Klaus. That actually gives us a nice bridge to the next topic we will discuss. And I'd like to turn now our focus to the management of advanced melanoma and skin tumors. And I'd like to invite Professor Celeste Lebay from St. Louis Hospital in Paris to share with us on how she managed her patients with systemic therapies in the adjuvant and the metastatic setting. Celeste?
Thank you, Alex. Hi, everyone. I'm very glad to be here with you today. Can I have the next slide, please? So, as everyone else, we can distinguish two periods for this management. The early phase of the pandemic in Paris, let's say mid-March to mid or late April, and later on. And in the early phase, like everyone, we were very worried by data coming from China, very alarming concerning the frequency of infections with COVID in cancer patients, which appear to be higher, and higher risk also of severe complication in this population, and also a theoretical risk, which didn't prove to be true at the end, but at the beginning, there were a theoretical risk to exacerbate the COVID symptoms using anti-PD-1, exacerbates severe forms, the cytokine storm, which is characteristic of this severe form of COVID. Please, can I have the next slide? So we had edicted rules for the Paris Great Area, the College of Dermatologists, to which I am leading, wrote some rules which are quite reminiscent or similar to what has later on been published by French guidelines in this period. So the main philosophy was to avoid as much as possible the presence of COVID in oncodermatology units. These units should remain COVID-free. And in order to do so, patients had to have separate pathways. The patients who came to the departments had a daily phone call the day before they came with a dedicated questionnaire in order to avoid letting these people come if they had a fever or any symptoms of COVID. And if they did, they were tested. We had not these problem which were depicted by Veronique, but the problem was for every country was the sensitivity of this COVID PCR, which, as everyone knows, is low. But we were able to propose this to our patients and also to the care providers in our institution. So having this in mind, please can I have the next slide? How did we manage, first of all, patients who were already treated by targeted therapies, either on the metastatic or in the adjuvant setting? Well, for these patients, these were the most easy cases. We asked patients to remain at home. We privileged telemedicine, phone calls. The logic was to avoid hospital if they had to had radiological workup. They did it near their home, or we delayed otherwise the workup. So that's what we did for targeted therapy. Next slide, please. On the other hand, patients already treated by immunotherapies on the metastatic or adjuvant settings, we advised on giving them either pembrolizumab every 6 weeks or nivolumab flat dose every 4 weeks in order to make patient venues as little as possible. And we tried to avoid skipping doses. However, we took into consideration for that certain factors. The most important was probably the age of the patient, and indeed the discussions and decisions were quite different with the age of the patients. And after 70 years old, we were very, very reluctant, at least for the first 3 or 4 weeks of the pandemic, to have this patient in the hospital. We also took into account other fragilities, hypertension, obesity, etc. And of course, patient's choice was very important to consider. And we had several patients who were frightened at the idea of coming to hospital, even some young patients, and we respected their decisions. One important criteria was the time already on treatment, meaning that for patients who were treated, for instance, for 1 year by anti-PD-1 and in partial remission, it was not a problem to skip 1 or 2 doses, whereas for patients who were on treatment for only 1 or 2 doses, it seemed to us a bit more complicated to skip those doses. For the patients for whom the doses were skipped, of course, we kept in mind that we had to be vigilant on biological surveillance, and this was done by telemedicine. Next slide, please. What about introducing new therapies in the adjuvant setting? We considered that this therapy could be delayed up to 12 weeks or even a little bit more for elderly patients. And as far as immunotherapy was considered, we would prefer providing pembrolizumab every 6 weeks, again, in order to limit patients' venues in our hospital. Next slide. Introducing new treatment in the metastatic setting. Well, at least for first-line therapy, as in many centers and countries, we privilege immunotherapy as a rule in first line. And outside the COVID pandemic, we much favor the combination Ipi-Nivo, but during the early phase of this pandemic, it was just the contrary. Ipilimumab, nivolumab combination induction was to be limited during this period because of the high risk of toxicities and the fear we had not to be able to hospitalize our patients, not only in ICU units, but also in standard COVID negative units. And we also anticipated a lot of problems in having access to radiology, endoscopies, all of these things which are mandatory to monitor toxicities. That's why during this period, we privileged the use of anti-PD-1 alone. Next slide. Next slide, please. So what do we do now? We have new data coming from US, coming from France, our country, coming from Italy and many other countries, which are quite different from the early data we had from China. Of course, we have the confirmation that mortality by COVID seems to remain high in thoracic cancers and in patients with hematologic toxicities, particularly when they are treated with chemotherapy. But on the other hand, patients treated with immunotherapy could be at less risk of COVID. At least that's what is suggested by Paolo Ascerto from Naples. So that's what he mentioned last AACR a few weeks ago. Klaus provided his experience in Tübingen, and our experience finally in Saint-Louis Hospital is also on the same at the same level. As a rule, no severe infection in patients treated by immunotherapy. I cannot tell really if immunotherapy prevents COVID infection, but at least we didn't see any severe infection. Next slide. So with this data in mind, and less patients infected, more access to ICU, we more or less have resumed our previous management before COVID. No more triage for infusion except daily call in order to check for the absence of fever, of COVID symptom. And of course, what is still relevant is distanciation rules, use of masks for everyone who arrive in hospital, and always try to maintain onco-dermatology unit COVID-free. What is a little new, but probably will not last, is the creation in some hospitals like ours of COVID plus cancer hematological units. And in fact, we did not use these units, but I know that my hematology colleagues have been obliged to induce some patients suffering from leukemia despite concomitant infection by COVID. It was a question of life and death. And so these units proved to be important for such patients. I think that was my last slide. So I thank you.
Thank you, Celeste. Thank you for this really nice overview. It's reassuring to hear that patients under systemic therapy, or particularly immunotherapy, at least in your experience, did not seem to have a high rate of severe COVID infection. I'm wondering whether Klaus Garbe has some information or some experience on patients under systemic therapy for melanoma who suffered from COVID infection. Do you have any information? Klaus? Or maybe I can also ask.
No, it's fine.
Okay.
So as I've already stated, we did not see a single COVID-19 infection in all our patients who were under PD-1 based immunotherapy. And so it's my question to Celeste, did you see such patients?
Yeah, we did. So of course, since all patients were questioned, we were proactive in detecting symptoms. And as long as they had not only fever, but cough or whatever symptoms which could be related to COVID, we tested them. And we did not hesitate if the symptoms were persistent, and if even if the COVID PCR were negative, to do a CT scan, which, as you know, is quite sensitive to make the diagnosis. So yes, we did see some cases, but as I said, not any patients had a severe form of COVID.
Thank you. It's a pleasure also to have with us Reinhard Dummer from Zurich, and maybe under the same topic, I'd like to ask Reinhard, did you also follow the same principles as mentioned by Celeste and Klaus in terms of the modification of systemic treatment in order to reduce visits, to increase the intervals between visits? What was your experience in using checkpoint inhibitors in the metastatic setting?
So Alex, thank you for this question. Actually, we don't really have to do something in this direction. In the other direction, we had a lot of patients and it was more the patient who said, I want to stay at home. Actually, our service was running normally, and we have also refused to give resources to the central area because also the need in our hospital, we had up to 260 intensive care beds, and the maximum number of patients with active COVID in intensive care were 20. So we had 180 empty beds, and we have offered help to centers, and especially to the southern part of Switzerland and the western part. But actually, it's not so easy to transfer patients from that are in intensive care units from hospital to hospital. So we had to defend our resources, and the patients actually started to get tested. And what we also wanted, we did many things like Celeste has described. I don't want to repeat that, but I think the improvement of compliance, and also that the patients keep their appointments for important surgery, them listen, we are prophylactically testing all inpatients. all patients that come to our hospital on a regular basis. So for example, all patients that come for irradiation therapy, for phototherapy, for immunotherapy, also for infusions, tested every 4 weeks. And this was very, very a big step ahead, because I tell you also our staff members were very concerned. And there was, I call this like a COVID shock, just did not want to move anymore. And everybody was applying for home office. But as you know, you can only do certain things in home office. And at least our service is typically quite overloaded. So if we don't work for 2 months, it will deal with the workload that is not done, you know.
Great, Reinhard, since you are on the podium now, you're running a renowned and busy dermatology center at the University of Zurich. And I'm wondering, how did your center reorganize patient care in order to, again, reduce visits of patients and minimally expose them to the risk of COVID infection, but ultimately not compromising the cancer care outcome? And another question also is, how did you manage other important activities like clinical trials, tumor board conferences? How were these managed during the outbreak?
Yeah, so I have to say that we are using a lot of Skype for Business now. So our hospital informatic team and they are like very strict with Zoom, for example. So therefore, I'm at home. I could not have the same conferencing system in the hospital because they are also strict about their firewall. But Skype for Business, I think a lot internally, and we had to do a lot of bad things for the students. For example, they could not attend tumor boards. Also, the numbers of residents was reduced. So it was. I think there was a lot of restrictions, unfortunately. We have to say it was not bad in Zurich in comparison to what our colleagues in Italy or in the UK or in Spain have experienced. I think we are more or less, I think, in a similar level than Klaus has reported. And here, so this is like a screenshot where we see that we had a daily information. So how many patients of COVID are in the hospital, how many are in intensive care, how many people were dying. So we received that every day. I would call a backup of personnel for more intense, for the big wave. We are waiting for the big wave, but the big wave did not come. As I mentioned, 200 beds available. And this meant that we were fighting to keep our researches, and we said we need a huge burden of cancer patients, and we cannot afford to stop for 3 months. There is no way to compensate for that. Maybe you just move on for this slide. So this was the internal information. So. And we really said, and this was also the position of the Swiss Dermatology Society, skin cancer treatment is, let's say, essential treatment, and this cannot be postponed, because as this problem is not solved. I think it's still around, and there will be another wave. So we cannot wait the whole year. And one other thing is, and this was already touched by some of you, I think one of our big frustration was that the reduced, and we had to shut down all our research units, but all the infrastructure was there. So we switched our PCR machines and extraction machines, and we did our own PET testing in the house. So all the staff testing is not sent to a virology lab, but it is done in our unit. And these are also from the Federal University, from labs. They were moved to our department, and we are internally now able to do up to 500 tests per day. And this was a huge initiative from our staff. And I tell you, this was really waking up the people and say we can do something against the disease just by knowing who happily, we tested all our 200 people in the house twice in the meantime. And we knew a few people, actually residents and nurses were infected, but they did not spread it. And we have no new infections. And this gives really a lot of confidence inside. And also, as I said, all patients that come as inside patients get obligatory test, and all patients that have regular visits. And finally, I think this is my message. So I think against the disease, I think we need the overview, because it's difficult to fight against the enemy that it's invisible. And the overview can just be achieved by testing. Unfortunately, the PCR is only valid for a week, so you have to really extend, can control it yourself. Thank you.
Thank you very much, Reinhard. There's one more slide here on clinical trials. Maybe you'd like to comment on this, Reinhard, because
we think we went through our clinical trials and we have discontinued the recruitment for inflammatory parts, also for psoriasis and these diseases. But for the cancer trials, actually, we were still ongoing. We offered, unfortunately, some of the pharma companies, they have decided to close down their studies. For example, BMFs, we have a number of BMF studies. And we have complained with them, and we say, well, we are working for a COVID-free area, and this is achieved, then we have the conditions that allow us to continue this very important work. Thank you.
Thank you very much, Reinhard. Celeste, very quick comment on clinical trials on your center, please, before we move on.
Yeah, well, the clinical trials, the patients were not enrolled in clinical trials during the early phase of COVID. Most companies, didn't want to. For patients who were already on trials, they had facilities to do their examinations outside hospital, to skip visits. And this was really a change since, as usually, the patients in protocols, they are very strict, and they have to come for their visits with strict conditions. There's one point that I wanted to add, maybe if we had time. We didn't cover that at all, and it was a problem. It was patients who were hospitalized, not with COVID, but for severe cancer. And those patients, during the early phase at least, they couldn't have visits from their families. And this was a real problem for many patients who were very ill, sometimes at the end of their life. And I think this ought to be mentioned.
Yes, that is a very correct point. Thank you very much, Celeste. I think we'll move on to the last topic. And for the interest of time, I'd like to invite Professor Veronique de Marmol, who's chairing the Department of Dermatology in the University of Brussels. And Veronique is also the chair of the Melanoma Prevention Program. And I'd like to ask you, Veronique, the time of the pandemic fell exactly at the time where many dermatologists and societies are conducting their annual prevention and awareness campaigns. And you've been very heavily involved in the Melanoma campaign, which for the first time in its 20-year history has been suspended for this year. I'd like to ask for your insight about Melanoma and also about prevention in the time of COVID-19.
Yes, thank you, Professor Stratigos, for inviting me. Just next slide. Just to say, indeed, we're running this campaign since 20 years now, and we try to give education, but mainly we do a screening during the campaign. So certainly we had to cancel every screening that we could do everywhere in Europe. But we try to, during this campaign, to continue to deliver a message for primary, secondary prevention. Next slide. And indeed, we realize also that in Belgium, people could still go outside inside the city, go into parks, and they still expose themselves. It was a very sunny time in Belgium, surprisingly, a very beautiful spring, and many people were exposed and burned by sun exposure. So at a certain point, we can think how to deliver prevention message when in such a period and it looks so maybe inadequate. I think it's perhaps forgetting that in Europe, 20,000 people are dying every year from melanoma, and more than 120,000 all over the world over about all the skin cancers. So the mortality is still high, and maybe even in such a period, it's still adequate to speak about prevention. So we continue our campaign through social media because we are we have a collaboration with the Global Melanoma Alliance. This is an alliance with melanoma patients, and we collaborate on a social media campaign, and this was particularly active during the campaign. We emphasize also all the aspect of self-examination. It was totally the opportunity to look at ourselves and be able to maybe diagnose a skin cancer that was not diagnosed before. So I think it was quite the only comment that I want to say. Next slide. So just to say that we emphasize and promote early detection by self-examination. That's all.
Yes, thank you, Veronique. I think it's important that we do remain stable in our recommendations for prevention. It's a very strenuous time for our societies, indeed, and you know, people are coming out of the lockdown, and many of them may be having an increased you know, sun-seeking behavior. They hear a lot about ultraviolet radiation and its effect on the virus. They hear a lot about vitamin D. So there will be a lot more confusion, I think. Veronique Bataille, what do you think? Should we try to refine our messages of prevention? Should we try to change our recommendations? What is your opinion?
Yeah, I mean, in England, we had an interesting time because we were not allowed to stop in a park. So people were not allowed to lie down, sit on a bench. And as soon as that got released at the end of May, the UK population went absolutely wild. They were like, oh my God, we can now sit down, we can now lie down in a park, and the weather continued to be beautiful, as Veronique de Marmol mentioned. So now we're seeing people really spending far too much time and yes, risky behavior because they feel like they've escaped something and they're a bit out of control. And I think another thing that's quite nice to mention for us as dermatologists is that I would like to educate the public about self-examination, because one of the way we could also minimize the impact of a second wave is to maybe as dermatologists educate our patient about COVID skin signs, which are often very good sometimes to detect infection before other symptoms of COVID occur, and patient could be tested earlier. And I think if we educate our patient to be very skin-minded and examine their skin and look for things and rashes and lesions, at the same time we should say, you know, while you are very skin aware, just make sure you are looking for any suspicious skin lesion at the same time.
Thank you. That's a very important point, and I agree with yourself. A skin examination can be indeed promoted, and I think the big lesson from the outbreak towards people is try to be healthy and try to manage all your medical problems. And in that context, I think it's important to really emphasize the message of really taking care of your skin as well, and focusing on self-skin examination as well. That's a really interesting point. I think we're finishing now the presentation of topics, and maybe if there are any questions and by the audience. There's one question about, vitamin D and how that may affect, the people's attitude in terms of sun-seeking behavior. I think that was covered, but I don't know if Veronique wants to mention anything in addition to that.
Yes, by the way, the level of vitamin D is quite important and may be in relationship with the level of inflammation that the COVID could give. So this was another argument that people were giving to be more exposed. Just to remind, it was not needed to be exposed aggressively to the sun to increase the level of vitamin D. Another thing was about the UV also, some well-known American politicians mentioned the need of UV, so just to separate UVC, that's it quite artificial on the earth, that we just need, that can be a way of sterilizing. Interestingly also, it said that the COVID is not stays alive long when it's a sunny day. I've heard that also. So this is another argument of people to be outside and exposed to sun. I think this some of the comments from the literature that came out just the last weeks.
Thank you. And there's one last question regarding teleconsultation and how much that has been helpful in really managing patients' follow-up who are already on systemic treatment. I think this is a question that is addressed more to Celeste and to Klaus. Would you like to make a comment on how much teleconsultation has helped you manage patients remotely who are on treatment?
Well, maybe I can start. I can say that we never skipped any consultation. Patients who could not come or for whom we didn't want to come to a hospital, they were systematically called on teleconsultations. So it served us a lot. And it was really appreciated by the patients. Of course, there are limits to these consultations. You cannot pulp notes, you cannot see the entire skin, you cannot, the psychological aspects is probably less well covered with these teleconsultation, but we all had the feeling that they were very useful.
Klaus? Would you like to make a comment also?
I can just confirm that. So we had a lot of phone calls with our patients, and let's say, especially patients who were worried because they were among the risk persons for the COVID infection. We could manage a lot with phone calls just.
Well, thank you very much. I think we need to close the session, and I would like to thank all the panelists for their excellent contributions. I think the conclusion from this interesting discussion is that it's really early to tell how much this epidemic will impact on our patients' care. But one reassuring issue is that despite the disruption in our patients' care, despite postponing visits or prioritizing surgeries or adjusting treatments or changing the daily routines, I think the message is that the skincare management was maintained, at least in the centers from which the panelists came, in a rather good and high quality. And also there are new opportunities that arise in terms of developing and providing high quality remote care. Communication has changed, education has changed, the way we communicate with colleagues also to discuss patients has also changed. And I think the most important lesson is that we all have learned to adjust to the new reality, to operate and make case-by-case decisions against a backdrop of a public health emergency. Hopefully in Europe, the worst is behind us or is getting behind us. But even in the case of a resurgence or a second wave of the epidemic, we certainly will be much more prepared and organized to meet the needs of our patients. And with these final words, I'd like to thank you on my behalf and on behalf of Professor Klaus Garby for attending this webinar. I'd like also to thank those who were technically supporting this webinar, particularly Ricardo Leite and then Kostadinos Leopiris, my fellow, who helped in sorting out the questions. And I'd like to give the podium to Mirto Trakatelli, who's chairing the EADV school committee, who would like to say a few final words for the webinar series on COVID and dermatology. Mirto.
Thank you, Alexander. And on behalf of the EADV Education Committee, I would like to thank all the panelists and you and Professor Garbe for chairing and organizing this beautiful COVID webinar. This is the last of a series. So during this era, we had a series every Thursday. We were joining our colleagues and trying to help out with different topics around COVID. This is our final, and I think it was not the least, it was one of the best. We really want to thank the Education Committee who did all this hard work preparing the webinars, and of course Ricardo Leite and all the officers of EADV that supported them. And I would like also especially to thank the panelists of tonight and the panelists of the previous webinars. We're going to do something special for them as they did a voluntary work. Nobody received any fees for these webinars. They gave their time and energy to share the knowledge with all of you. So I want to thank all again the panelists of all the webinars, and let's hope we do not need to make a COVID series again. Thank you.
Thank you.
Good night to all. Bye-bye.
Stay safe.
Bye-bye.